Okay. Are my slides visible?
Yes, sir.
It's visible. Please go ahead.
Okay. So a very good evening to everyone. So first and foremost, I would like to thank HFAI and Professor Sandeep Seth, sir, for giving me this wonderful opportunity on this platform. So I'll be dealing the management of chronic heart failure. And before I proceed to the management per se, since we have discussed the diagnosis of heart failure in the previous session, I would like to briefly revise upon those topics. So, as we know, heart failure is not a single disease or a disorder. It is a complex clinical syndrome. It can be due to a variety of causes and it can be uh, presented in a variety of clinical presentations. However, most commonly it presents with breathlessness on exertion and it's a progressive disorder. It can then progress to breathlessness at rest and then patient can present with breathlessness on lying down, which is called as orthopnea. The other signs and symptoms of fluid overload or congestion in the form of pedal swelling or abdominal swelling. And on examination, one can find lung crepitations bilaterally. These are again the signs and symptoms of heart failure. So everyone has come across this anatomical diagram of the heart, which shows the four chambers, the right atrium, left atrium, which are guarded by the atrioventricular valves, then the ventricles, which open into the great arteries, and they are again bounded by the semilunar valves. So, coming to the causes of heart failure, the first and foremost is valvular obstruction or regurgitation at any level. Then we have decreased heart muscle contractility, which is called as systolic dysfunction of the heart. Again, the defect can be in the right ventricle muscle or it can be in the left ventricular muscle. And then we can have hypertrophy of the muscle of the heart, which leads to a difficulty in relaxation, which is called as diastolic dysfunction. So all these abnormalities can ultimately lead to a situation where there is decreased cardiac output, that is decreased ejection of blood from the heart, and increased filling pressures in any of the chambers of the heart. So all these contribute to a complex clinical syndrome with the symptoms we'll discuss in detail again. So coming to the symptoms of heart failure, it can be divided grossly into right heart failure or left heart failure. So right heart failure, since there is elevated filling pressure in the right side of the heart, which is the right atrium and the right ventricle, which ultimately leads to congestion in the SVC and the IVC, superior vena cava and the inferior vena cava. You can have liver congestion, which leads to loss of appetite. You can have lower leg edema, and you can have weight gain. Similarly, if there is elevated filling pressure in the left side of the heart, which is left atrium and the left ventricle, the patient can develop shortness of breath, which can progress to breathlessness on lying down, which is called as orthopnea. So now I proceed to the management of chronic heart failure per se. So I'll be dividing it into a non-pharmacological management and pharmacological management. So coming to non-pharmacological management, first and foremost, salt restriction is very important. So because these patients are generally fluid overloaded, so we advise these patients to restrict salt in their diet to the tune of less than 2 to 3 grams per day. And this has been shown in various studies to reduce congestion. Secondly, we ask these patients to restrict fluid in their diet. So this is very important, especially in patients who are fluid overloaded or patients who have symptomatic hyponatremia. So fluid restriction would help bring their sodium to normal levels. Then we advise these patients to have exercise training. We advise proper nutrition because often heart failure is a chronic inflammatory state, and these patients are generally cachectic. They have significant weight loss. So nutrition is very important. Again, we then advise these patients to undergo vaccination yearly. The most important vaccination in these patients is pneumococcal and influenza vaccine, and these have to be administered annually because infections in the form of pneumonia are one of the foremost causes of worsening of these patients. And then, if the patient is obese, we again advise for weight reduction. An important treatment in these patients is iron therapy. So what we do is we screen these patients for iron deficiency at baseline, and then we have to repeat an iron profile annually. So iron therapy is indicated if the serum ferritin is low to the tune of less than 100 microgram per ml, or if the serum ferritin is between 100 to 300, but the transferrin saturation is low, that is less than 20%, we go for IV iron supplementation. So it is important to note that oral iron does not have any role in the management of chronic heart failure because these patients generally have gut edema or bowel edema, which will hinder the absorption of iron. So iron is always to be administered in an intravenous form. So the most common formulation nowadays which is used is iron ferric carboxymaltose. And before we calculate the dose, we have to calculate the iron deficit, which is demonstrated by this formula. It is based on the body weight and the actual hemoglobin of the patient at that point of time. So it is provided in two doses. So the first dose is given as 15 milligram per kg, and which can be given to a maximum of 1000 milligram in one setting. And then we repeat the second dose to cover the remaining deficit after a period of 6 weeks. So this iron therapy is to be given as an infusion and generally over at least 1 hour. So coming to heart failure phenotypes. So before we proceed to the pharmacological management, it is important to know that the management depends on the heart failure phenotype. So the most important parameter to divide these patients is LV ejection fraction by 2D echocardiogram. So if the LVEF is less than 40%, it is termed as heart failure with reduced ejection fraction. If the ejection fraction is 40 to 49%, it is mildly reduced ejection fraction. And if it is more than 50%, it is called as preserved ejection fraction. So why this is important to know? Because the heart failure therapy or the pharmacological management will be tailored according to these phenotypes. So coming to the heart failure with reduced ejection fraction, that is when the EF is less than 40%. So the maximum body of evidence right now is for this phenotype. And we have a number of drugs which have proven time and again to provide mortality benefit in this phenotype. So the drugs which are used for this phenotype are ACE inhibitors, ARBs or ARNIs, beta blockers, mineralocorticoid receptor antagonist, and SGLT2 inhibitors. And we supplement these patients with loop diuretics for fluid retention. And when these drugs have been given at maximally tolerated doses and the patient is still symptomatic, we can go for other device therapies in the form of CRT or ICD for sudden cardiac death prevention as well. So we'll be discussing these drugs in detail subsequently. So coming to the second phenotype, which is mildly reduced ejection fraction, that is when the EF is 40 to 49%. So the maximum evidence right now we have for this phenotype is in the form of either diuretics for fluid retention or SGLT2 inhibitors, which are dapagliflozin or empagliflozin. The other drugs right now just have a class 2B or a very weak recommendation for mildly reduced EF. Then the last phenotype, which is preserved ejection fraction, that is EF more than 50%. Again, there is only class 1 or very strong recommendation for only two drugs, that is diuretics and SGLT2 inhibitors, which is dapagliflozin and empagliflozin. And at the same time, we have to treat other cardiovascular and non-cardiovascular comorbidities as well. So now we'll discuss drugs for chronic heart failure in detail. So a simplified format is the ABCD format. So A pertains to ACE inhibitors, angiotensin receptor blockers, and ARNIs. B pertains to beta blockers. C are generally complementary drugs, which include SGLT2 inhibitors, vericiguat, ivabradine, digoxin, isosorbide dinitrate hydralazine combination. And D pertains to diuretics. So it is important to note that the drugs highlighted in bold, which is ACE inhibitors, ARBs, ARNIs, beta blockers, SGLT2 inhibitors, and mineralocorticoid receptor antagonists, they have been shown to prove a survival benefit. So that is when we provide these drugs to these patients at maximally tolerated doses, we can actually add years to this patient's life. So these are the drugs which constitute the four pillars of heart failure therapy and have been shown to have a survival benefit. So coming to the first drug, which are ACE inhibitors, ARBs or ARNIs, they actually inhibit the renin-angiotensin-aldosterone system. This RAS system is overactivated in chronic heart failure and it causes adverse cardiac remodeling. So if we inhibit this system, it will cause reverse remodeling of the heart and improvement in ejection fraction of the heart. So ACE inhibitors, the most commonly used drugs we know are ramipril and enalapril. Similarly, ARBs, they include losartan, valsartan, and telmisartan. However, it is important to note that telmisartan does not have a very strong evidence in chronic heart failure. It is losartan and valsartan which have been shown to provide a survival benefit in chronic heart failure. ARNIs include sacubitril valsartan combination. So we start these drugs at very low doses and then we up titrate based on the patient's blood pressure every 2 weeks or so. Then it is important to note that we should never combine these three classes of drugs, namely ACE inhibitors, ARBs, and ARNIs. ARBs and ARNIs. So one of the drugs should be given, and we have to monitor the blood pressure, KFT, serum potassium of the patient on a serial basis. So these drugs can cause hypotension. So these drugs should be modified, or we should raise an alarm if the systolic blood pressure is less than 90 millimeters of mercury. So it is always important to inform the physician so that we can titrate the drug dose. These can cause dry cough, which will not generally respond to antitussives. So it is important that these drugs be stopped if the patient has a dry cough and it is not subsiding, and we do not have an alternative diagnosis. So these patients can also develop life-threatening angioedema. So if the patient develops angioedema with these drugs, they should never be started again. So this table summarizes the common available drugs and the common brand names and the starting doses and the maximum doses of these drugs. So among ACE inhibitors, we have ramipril, which is generally started at a dose of 1.25 to 2.5 milligram OD, and we slowly uptitrate these drugs every 2 weekly or so, and we reach the maximally tolerated dose of the drug. Coming to beta blockers, so the second system which is overactivated in chronic heart failure is the sympathetic nervous system. As discussed before, this system again causes adverse cardiac remodeling of the heart, and it is important to inhibit this overactivity. So the three important drugs under this category are metoprolol succinate, carvedilol, and bisoprolol. So again, you should note that it is metoprolol succinate which has been shown to provide a mortality benefit in chronic heart failure, and it is not metoprolol tartrate. Metoprolol tartrate is the shorter acting version of metoprolol and has not been shown to have any mortality benefit. So again, as in the previous category of drugs, we slowly uptitrate the dose every 2 weeks or so. And similarly, because we are inhibiting the sympathetic nervous system now, so inhibition will lead to bradycardia. So it is important to always note the heart rate of these patients, the target heart rate being 50 to 60 beats per minute. And we should never start the drug if the patient is hypotensive or if the heart rate is less than 50 per minute or the patient has clinical congestion. So beta blockers are always to be started in a patient who is euvolemic, who has been adequately decongested, or otherwise we will end up harming the patient. So again, coming to the common drugs and common brand names. So we have discussed that metoprolol succinate, carvedilol, and bisoprolol are the three drugs under this category. We again start at a very low dose, uptitrate every 2 weeks, and try to reach the maximally tolerated target dose of the drug. So the third category, which category of drugs which have been shown to uh, provide mortality benefit in chronic heart failure is sodium glucose transporter 2 inhibitors. So this receptor is actually present in the proximal convoluted tubules of the kidney. And what these drugs do is they inhibit this receptor. This receptor is responsible for glucose reabsorption in the proximal tubule. And if we are inhibiting this receptor, it will lead to glucose excretion, and similarly by the osmosis, it will lead to free water excretion as well. So the drugs under this category include dapagliflozin and empagliflozin. And since these drugs cause glucose excretion in the urine, there can be genitourinary infections, dehydration, hypotension, and even hypoglycemia. So we have to be cautious of these side effects. So the starting dose of both these drugs is 10 milligram OD. So coming to the last category of drugs, which is diuretics. So diuretics, what they do is they decrease the systemic and pulmonary congestion. So we have discussed that heart failure is a fluid overload state. So they decrease the systemic and pulmonary congestion by sodium and free water excretion. Again, we have three categories of diuretics. So they can be either loop diuretics, which commonly include furosemide and torsemide. We can have thiazide diuretics. Most commonly used is metolazone. And we have another category of diuretics, which is mineralocorticoid receptor antagonist, which actually are a weak form of diuretics, but these drugs have been shown to have mortality benefit. And this category includes spironolactone and eplerenone. So while loop diuretics and thiazide diuretics, they cause hypokalemia, mineralocorticoid receptor antagonists are actually potassium sparing. So a combination of both of these drugs will help us maintain a potassium balance. So the side effects of MRAs will include hyperkalemia, and a very common side effect, which is only seen with spironolactone, is painful gynecomastia. So if the patient is presenting with gynecomastia with spironolactone, it is always prudent to switch to eplerenone, which does not generally have this side effect. So again, highlighting the important drugs, furosemide, which is commonly known by the name of Lasix. So the starting dose we start it orally is 20 to 40 milligram, either once daily or twice daily. And the maximum daily dose is up to 600 milligram. Another common drug is torsemide, which is started at 10 to 20 milligram once daily, and we can go up to 200 milligram daily, depending on how the patient's congestion is relieved or not. Among the thiazide diuretics, we have metolazone, which is started at a low dose of 2.5 milligram OD, and we can uptitrate it to 5 milligram once daily. The important category is mineralocorticoid receptor antagonists, which have a mortality benefit, which includes spironolactone and eplerenone. So, besides the drugs which have a mortality benefit, we also have complementary drugs for chronic heart failure. So, one of the drugs is ivabradine, and this is only approved for patients with heart failure with reduced ejection fraction. And this can be given to patients who are not tolerating beta blockers. Then we have another drug, which is a newer drug, vericiguat. This is again approved for patients in heart failure with reduced ejection fraction and patients who have worsening heart failure despite the four pillars of therapy. Another patient with another drug which is beneficial in patients with heart failure and kidney disease is isosorbide dinitrate hydralazine combination, as this has been shown to be uh, safe in chronic kidney disease. And another drug is digoxin, which can help with rate control in atrial fibrillation and can be used in patients who have both heart failure and atrial fibrillation. So these are the common drugs which are used and the doses. I'll not go into detail. So beyond drugs, so if the patient is already on four pillars of therapy now and is either still symptomatic, we have device therapy in the form of cardiac resynchronization therapy. So it is only indicated in patients with an ejection fraction of less than 35 pace percent and patients who have left bundle branch block on the ECG. And these patients should be symptomatic despite optimal medical therapy. Then we have another device therapy in the form of AICD, and this is indicated in patients with heart failure with reduced ejection fraction who have either had a sudden cardiac death and they have survived that sudden cardiac death, or the patients who have had a sustained ventricular tachycardia. So, how to identify patients who are eligible for a cardiac resynchronization therapy? So, as discussed, these patients have to have LBBB on the ECG. So, how do you identify LBBB on the ECG? So, you look at leads V1 and leads V5 or V6. So, if you notice, there's a W pattern which is seen in the lead V1, and you can see a notch in the downstroke of the S wave in lead V1. And similarly, if you look at lead V6, you can notice an M pattern in lead V6. Again, there is a notch in the upstroke. And these patients have a relatively wide QRS which is more than 120 milliseconds in duration. That means three small boxes on the ECG. So if the patient is in sinus rhythm, has left bundle branch block on the ECG, that patient is a candidate for CRT, provided his EF is less than 35%. Thank you. So now I'll proceed to a couple of questions. So everyone, please try to answer. Can we have the poll, please? So a 45-year-old male, he was diagnosed with dilated cardiomyopathy and he has an ejection fraction of 30%. So which of the drugs prescribed will not have any mortality benefit? So the options are enalapril, dapagliflozin, metoprolol, and telmisartan. So everyone, please try to answer. Uh, give you 30 seconds. Okay, so I have the results. So most of them have answered it correctly. So telmisartan, although it is an angiotensin receptor blocker, it has not been shown to have any mortality benefit. Enalapril is an ACE inhibitor, dapagliflozin is an SGLT2 inhibitor, and metoprolol is a beta blocker. All these three drugs have been shown to have mortality benefit in chronic heart failure. Okay, so this is my second question. Can we have the poll, please? Poll, please. So a 30-year-old female with heart failure with reduced ejection fraction has presented with bilateral pedal swelling and worsening breathlessness on exertion. So which of the following drugs or therapy must not be prescribed? Fluid and salt retention, metoprolol, furosemide, or spironolactone? Okay, I can't see the poll.
Just a minute.
Okay, please, everyone try to answer this. Yeah, so the correct answer is metoprolol. So as previously discussed, beta blockers should always be prescribed to these patients when they are euvolemic. And since this patient has presented with clinical congestion, it is always prudent to provide fluid and salt restriction and diuretics in the form of furosemide and spironolactone. Okay, thank you.
So with that, from chronic heart failure, we now move to acute heart failure. Dr. Prerna Garg will pick up acute heart failure. Prerna, please.
Thank you, sir. Can you please allow me to share my slides? Good evening and welcome to this session on management of acute heart failure. I'm Dr. Prerna Garg. Can I have my first question, please? So this is my first question for all of you. Please pick one of the choices and click on submit. How is everyone doing today? I cannot see the answers yet. Okay, excellent. So most of us are doing very good after that excellent talk on chronic heart failure. Some of us are not doing so good, two of us are doing very, very badly. I hope after this talk we all feel better. How do I go to the... So we have discussed what is chronic heart failure. A chronic heart failure patient is very good. They are in their usual state of health. They have some symptoms, but they are not worsening and they are living their life as usual. A worsening heart failure patient is not so good. They have worsening of their symptoms. There is a progressive deterioration in their symptoms in a patient who already has heart failure. This usually occurs in the outpatient setting and requires an escalation of therapy. If we identify and treat worsening heart failure patients well, we can prevent hospitalization. And what if we don't? We get patients of acute decompensated heart failure. These are the patients who are doing very, very badly. They have a sudden or gradual onset of symptoms that is so bad that they require urgent medical evaluation and treatment. Usually, these patients will require hospitalization and will present for emergency care. So what usually causes heart failure? These are the top 5 precipitants of acute heart failure. Most of our patients have poor medication adherence. Sometimes patients miss their diuretics, miss their heart failure medications, take too much fluids or too much salt in their diet. They may have an infection. Even minor infections like influenza may precipitate heart failure in these patients who are sick. A lot of patients develop an acute coronary syndrome. They may have a STEMI or a heart attack, which has caused acute worsening of the heart function, leading to acute heart failure. Uncontrolled hypertension is an important precipitant of acute hypertension. Sudden increased BP results in increased afterload on a heart which is already weak, and this heart fails in the setting of a high BP. And arrhythmias. A lot of us have seen these patients in our wards. Young patients with valvular heart diseases like MS worsening acutely because of the precipitation of an arrhythmia like atrial fibrillation. So how do we pick up these patients of acute heart failure? A patient in left heart failure is like this gentleman that we see on the left side of our screen. The patient cannot breathe. He has gross pulmonary edema. He cannot lie down flat. He has orthopnea. When he lies down, after a few hours, he has to get up because he is suffocating. He seeks out a window. He has paroxysmal nocturnal dyspnea. When the patient tries to exert or do any exercise, he feels dizzy. There is blackening in front of his eyes. He has syncopal and pre-syncopal attacks. The patient is chronically tired. He has fatigue. While a patient of right heart failure, please give me a second. A patient of right heart failure is like this female who is on the right side of the screen. Her whole body is swollen up. She has anasarca. Her neck veins are distended. Her JVP is raised. Her liver is distended and congested, leading to right upper quadrant dull pain. She can't breathe due to fluid in her lungs. She has pleural effusion, and her stomach is distended due to ascites. So how do we diagnose these patients? Any patient who is coming to us in heart failure, step 1, check the vitals. Blood pressure must be recorded. It may be high or low. These patients will usually have tachycardia, an increase in the heart rate. They will have tachypnea, an increase in the respiratory rate, and may have low saturation, an SpO2 that is low. We must record temperatures because infections are a common precipitants of heart failure. Now we will assess for the symptoms and signs that we just discussed. Now, what are the red flags that we must pick up in each patient? An oxygen saturation of less than 90%, hypotension, SBP less than 90, chest pain or suspected, a patient who is so sick that his GCS is dipping. These require immediate medical escalation and IV therapy. All patients of heart failure who are coming to us must have a panel of tests. We should have an ECG to rule out acute cardiac syndromes and arrhythmias. We should have a chest X-ray to look for infections and to see for pulmonary congestion. Blood tests including BNP, NT-proBNP for heart failure, troponin for ACS, CBC for anemia and leukocytosis. Anemia is a common precipitant, so is infection. RFTs for kidney injury. So the patient may have baseline CKD which may have worsened or may have acute kidney injury in this setting. And LFT to pick up ischemic hepatitis which will affect our drug choices later. And electrolytes to look for dyselectrolemias like potassium abnormalities. If the patient is severely unwell, an ABG should also be done in these patients. So does our BNP or NT-proBNP support heart failure? If the BNP is normal, it is an excellent rule-out test for heart failure. If BNP is normal, we should look for alternate causes of dyspnea. If it is raised, it supports our diagnosis of acute heart failure. Alternate causes of dyspnea include COPD, pneumonia, pulmonary embolism, renal failure, and ACS, and may also coexist with our acute heart failure. Finally, the patient can undergo an echocardiography to identify the various phenotypes and causes of the acute heart failure. So how do we manage these patients? Now I ask you to look for only two things in every patient of heart failure you see. The first thing we are going to see are their peripheries. We are going to see if the patient is warm or cold. A warm patient has normal BP, his peripheries are warm. A cold patient is hypotensive, peripheral vasoconstriction has set in. The second thing I want you to search for is if the patient is wet or dry. A wet patient has creps in the lung and has peripheral edema, while a dry patient, no creps, no edema. Based on this, we will classify our patients into 4 types, and this is our entire management of acute heart failure. If a patient is dry, his BP is normal, and is dry, there are no creps, and warm, his BP is normal. This patient can be sent home only after adjusting oral therapy. We can increase the dose of diuretics, we can optimize his medication, and advise follow-up on an OPD basis. If the patient is warm, his BP is normal, but he is wet, this patient is sick. If his BP is very high, then the patient would benefit from vasodilators, which would reduce the afterload, which will reduce the pressure against which the weak heart has to work. If there is mainly congestion, his BP is in his 90s or 100s, the patient would benefit from a high dose of diuretics. Now, if the patient is dry and cold, that means his BP, blood pressure is low, he has hypoperfusion, and there are no creps in the lungs. There is no peripheral edema. This patient is fluid depleted. It is possible that he has not had enough fluid or too much diuresis has been given. This patient will benefit from a fluid challenge. 200 to 250 ml of IV fluids may be tried in such patients to see how the blood pressure responds. The fourth phenotype is a wet and cold patient. These are the sickest patients. Their blood pressure is low. They cannot breathe because they have lots of creps in their lungs, and they are fully congested. They have extreme peripheral edema. So if the blood pressure is very low, the systolic BP is less than 90, then the patient needs to be started on an inotropic agent. The patient may also require both patients will require diuretics, and this patient may also require mechanical circulatory support and critical care. So what is critical care support? ABC, airway, breathing, circulation. Step 1 is airway. Assess the sensorium. If GCS is less than 8, you may need to secure an airway. If the saturation is low, SpO2 is less than 90%, the patient needs some sort of oxygen supplementation. The patient may even need ventilatory support in the form of NIV or intubation. For circulation, establish a large bore IV access. Inotropes require central venous access. Initiate diuretic therapy promptly, and in patients with severe hypertension or regurgitant lesions like MR and AR, early vasodilator therapy may be beneficial. To ensure that circulation to the kidneys is adequate, every patient should have urine output monitoring from the moment of admission. We need to reduce volume of medications in IV medications. We should not be giving too much IV fluids to the patient, and we should maintain upright posture in all patients. Now, when will you give NIV? So NIV reduces need for intubation, improves respiratory failure, and improves mortality in patients of ADHF. Any patient not tolerating oxygen or with creps in the lung would benefit from a trial of NIV. These patients usually need a persistent pressure. They do not need a peak inspiratory pressure. So the PEEP usually is set at 5 to 8, and the PS can even be kept at 0. Usually it is kept between 3 and 5 so that the patient has some support for inspiration. The FiO2 should be titrated enough to maintain saturation from 88 to 92%, that is around 90%. Use these settings initially and then titrate according to the patient's response and respiratory rate. At this point, try to identify and treat the precipitating factors. So if the patient has had too much fluid or salt intake, this patient will benefit from diuretics. If there is an arrhythmia like AF, the patient may benefit from DC cardioversion. Ongoing or worsening ischemia causing heart failure needs revascularization. So does the patient need to undergo stenting or CABG is a call that needs to be taken. A patient with severe emotional or physical stress, for example, just post-surgical, may benefit from some amount of IV sedation. Patients with worsening renal failure, may need hemodialysis and should be evaluated. Poorly controlled hypertension, as we have discussed, requires starting of a vasodilator therapy. Septic patients would benefit from IV antibiotics. Hyper and hypothyroid patients would benefit from correction of their thyroid status. Acute MR and AR, again, as we discussed, needs the initiation of vasodilator therapy. Patients in alcohol withdrawal often have thiamine deficiency, which precipitates heart failure. So these patients also benefit from supplementation of thiamine. So what do we use in vasodilators? Most of us use NTG since it is easier to administer and is freely available. Nitroprusside is a more effective arterial vasodilator, however has a side effect of causing cyanide toxicity. How do we prescribe NTG? We make a solution of 50 mg by 50 ml that we start at 0.6 ml per hour infusion. We can increase it every 5 minutes by 0.3 to 0.6 up to a maximum of 12 ml per hour. If possible, establish an intra-arterial BP line for your patients. If not, monitor the BP every 15 minutes. That is how rapid our therapy needs to be. I will pause on this slide for a second. This is from our cath lab. This includes the usual dilutions of commonly used inotropes and vasodilators and the usual infusion rates and the rates which you are supposed to give them in. You can take a picture to have this in your phone for ready reference when you are making the drugs. Moving on to the next pillar of treatment, diuretics. It is indicated in all patients with ADHF. Now, should we give the diuretic as an IV or oral drug? So I would bring your attention to the top right figure. This is a diuretic time dose response curve. As we know, when we give any drug IV, there is a sudden peak in concentration which weans off faster, while an oral drug will take more time to act. So sick patients will always need an IV therapy, while patients who are warm and dry may even benefit from increasing the dose of an oral therapy. In patients who are ADHF, the threshold for response to diuretics also increases. So these patients require much higher doses than normal than normal healthy patients. When you are giving IV, should you prefer a bolus or a continuous infusion? So trials have shown that there is no significant difference. We usually start with bolus for ease of administration, but if the patient is very sick, we shift to continuous infusions because they are easier to titrate. Now, once we have given the diuretic, what dose do we want to give it at? An empiric therapy should be administered at 2.5 times the home dose. So suppose the patient is taking 40 mg Lasix at home, your first dose of diuretic in hospital should be 100 mg IV Lasix. If the patient is not on diuresis at home, or you do not know how much diuresis he is taking, you can start him on furosemide 80 mg, that is Lasix 80 mg as the first dose. Now, how do we monitor our response? Since most of us do not have urine spot sodium available, we look at the urine output pathway, which is on the right side of the screen. If the urine output is between 100 to 200 ml per hour, roughly 150 ml per hour, our dose is adequate and we can continue this same dose. If it is less, then we need to double the previous dose directly up to 300 mg of furosemide equivalent. Now suppose the patient does not respond to this dose also. What else can we add? Mineralocorticoid receptors. They have an additive diuretic response. They help overcome diuretic resistance. They prevent hypokalemia. Loop diuretics cause loss of calcium, while MRAs retain potassium, while MRAs retain potassium. And they have a mortality benefit. So this can be an add-on therapy in your patient who is not responding to Lasix. What about chronic heart failure treatment? So we have seen that they have a mortality benefit in patients of chronic heart failure. And often patients who are coming to us are worsening of chronic heart failure. They may already be on these medications. So what should we do with them? If the patient is stable, warm, BP is normal, you can safely continue the beta blocker. If the patient has mild fluid overload, there is some edema, but no creps, stable BP, you can still continue the beta blocker. However, if the patient is sick, there is hypotension, bradycardia, shock, any need for inotropes, we need to stop beta blockers. Now that we have stopped beta blockers, when can we start them? Not during acute heart failure. Only once the patient is stable for 24 to 48 hours on oral therapy should we start or up titrate beta blockers. Practical points while giving beta blockers: always check the heart rate and BP before you give any dose. Watch for bradycardia, heart rate less than 55, hypotension, SBP less than 90, or if the patient starts complaining of dizziness and fatigue. What about RAS inhibitors? Similarly, if the patient is stable renal profile, you can continue the dose he is taking at home. But if the patient becomes hypotensive, if the potassium rises, or if there is any kidney injury, we should hold these and reinitiate after the patient stabilizes. When can we initiate? Once the SBP is more than 100 and the patient is off IV vasodilators for at least 6 to 12 hours. Always monitor the blood pressure, potassium, and creatinine at 1 to 2 days after initiation or dose change. SGLT2 inhibitors can also be started during hospitalization once stable. There is no need to wait for full stabilization. If the SBP is more than 95, the patient is stable, and there is no acute kidney injury, you can safely initiate an SGLT2 inhibitor in hospital. Always check the renal function before starting. Now, as Kshitij sir described, SGLT2 inhibitors cause excretion of sugar in the urine. So it is associated with increased risk for UTI and genital infections. So watch for these. If the patient was admitted with a UTI, probably not a good idea to give them SGLT2 inhibitors. And educate the patient to maintain adequate hydration and not get rehydrated. A new drug on the block for acute heart failure, vericiguat, is an oral soluble guanase cyclase stimulator. It improves the nitric oxide pathway, enhances myocardial and vascular function. It is indicated in patients like these, patients of chronic heart failure who had recent heart failure hospitalization on GDMT. It is an add-on therapy to our 4 pillars of therapy. It has been shown to reduce cardiovascular death or heart failure hospitalization by 10% in high-risk heart failure patients. So how do we start? We start at a low dose of 2.5 mg once a day, and then every 2 weekly, we increase it to a target of 10 mg once a day. This drug also causes hypertension, so monitor blood pressure. Taking it with food causes better absorption, so that is something we can advise to our patients. And because it is a vasodilator, avoid it with nitrates or PDE5 inhibitors. Hydralazine and isosorbide dinitrate, which we all know as isolazine, has the main advantage that it can be safely used in advanced CKD. CKD patients can be given this. It is also a vasodilator, but always check blood pressure and heart rate before every dose. It causes extreme orthostatic hypotension. So whenever you give isolazine to the patient, advise them for slow position changes. Do not get up suddenly from lying down position. Turn to your side, sit up, hang your feet down, and then get up from lying down position. And because it includes a nitrate, it sometimes causes a headache initially, which is well tolerated and usually resolves after taking the drug for some time. Now that our patient is stable, how do we plan for discharge? For discharge, our patient should have stable vitals for more than 1 to 2 days and no requirement of IV diuretics in the last 24 hours. For 24 hours, the patient should maintain adequate urine output on oral diuretics. We should have optimized and counseled him regarding the medicine. All 4 pillars, as much as possible, have been initiated. While we are discharging, we explain to the patient the use of each of these 4 pillars. We indicate the purpose, the dose, the timing, and the side effects of the drug. And we provide them with a written discharge, which has the written medication plan. For self-care and education, at our center, nurses lead in teaching the patients heart failure management. We teach them the 3 R's of heart failure. Recognize the symptoms early. The patient should be able to tell that they are getting more short of breath, there is more edema, they are becoming fatigued earlier. When they recognize their symptoms, they should know what to do. They should respond. When do they have to come into the emergency? Can they increase their dose of diuretics at home? Can they just take 2 tablets of Diator? And they should monitor themselves well. They should record their weight and fluid status daily. In terms of fluid and salt management, we teach patients to limit fluids to less than 1.5 to 2 liters per day and reduce salt intake to less than 5 grams per day. For this, we advise them on foods which have a high concentration of salt. For medication adherence, since heart failure has a lot of medicines which the patient has to take, pill boxes or medication charts may be useful. We should tell the patients to continue taking the medicines as we prescribe them. Often patients say that I was feeling better, so I stopped taking my blood pressure medication. So tell the patient clearly, do not stop this medicine when you feel better. And use the teach back method. Once you tell the patient what to do, ask them to tell you again. Can you tell me how you will take your medicines at home? All patients ask if they can resume normal activity at home. So advise them that they can start light activity once they are stable. Walking 10 to 20 minutes per day should be okay, and they should maintain a daily step log. So everyone has a step counter on their phone at this time. Advise them that if you are taking 5,000 steps today, next week reach 7,000. The week after that, try to reach 10,000 and gradually increase your exercise. Tell them to avoid sudden heavy lifting and stop exercises if they get very dizzy or breathless. Very importantly, advise them to monitor themselves at home. Every day, they need to take their weight and report if their weight gain is more than 2 kgs in 2 to 3 days. It is not possible that they have eaten so much that they have gained 2 kgs in 2 to 3 days. It is worsening heart failure. Fluid has been retained. If there is any swelling of feet or abdomen, breathlessness or reduced urine output, make a red flag card or print it in your discharge that if you have these symptoms, please come to us immediately. Advise them on vaccination and preventive measures and schedule the first follow-up, which should be within 7 days of discharge. This is the heart failure checklist we use at our center. This includes everything that we have just discussed. The use of diuretics, IV inotropes, ACE inhibitors, ARNIs, beta blockers, anticoagulations for patients who are bedridden or who have AF. It also includes other aspects of care. What was the precipitating factor? Was there CAD? Does the patient has diabetes? Has the patient been vaccinated? And if not, then when can we plan a vaccination? Health counseling is a vital part. We talk about exercise, discharge counseling, smoking cessation, and we encourage a follow up within 7 days. So, can I have my next question, please? This is a 65-year-old patient with known heart failure who presents with weakness and dizziness. His blood pressure is 82 by 54, heart rate is 118, saturation is 95%. There are no creps on auscultation. What is the most appropriate next step? Please pick one of the options. Can I see the answers, please? I cannot see what everyone has answered. The correct answer is option C. This patient is cold and dry. So this patient would likely be volume depleted and needs a cautious fluid trial. My second question, please. Okay, I have the answers. Most of us have given the correct response that we should give IV fluids. Moving on to the next question. A patient with known heart failure presents with increasing breathlessness, orthopnea, and edema. His saturation is 88% and respiratory rate is 32. What is the most appropriate first action? I want you to pick the thing you will do just immediately next. Okay, I can see the answers. Most of us are getting it right. This patient is sick. There is a red flag. His saturation is low. The patient needs to be started on oxygen and be given a trial of NIV. Almost all of us got this question right. Can I have the next question, please? A patient with ADHF. A patient with ADHF is on IV loop diuretics. Urea creat is 36 by 0.9. Over the next 24 hours, urine output is adequate. It is 100 to 150 ml. A repeat KFT shows urea creat 42 by 1.2. The patient is clinically improving. What is the most appropriate next step? So the house is divided on this question. The correct answer is C. You will continue the same regimen. A mild increase in creatinine indicates effective diuresis is occurring. Do not stop or reduce diuretics if the patient is clinically stable. Creat of 0.3 by 0.5 is acceptable. Thank you for your time and attention in this talk and the great work you do every day bedside with patients. This is our heart failure team from a recent celebration which contains nurses, research staff and clinicians. Thank you all.
Thank you, Prerna. So if you can stop sharing. From this talk, now we go on to two cases which will illustrate the entire discussions we've had so far with Kshitij and Prerna. Devesh will present a case of chronic heart failure, and then Neha will present the case of acute heart failure. Devesh, please.
Are my slides visible, sir?
Yes, they're visible.
Yeah. So a very good evening. Without much ado, I would like to discuss a case-based approach of a patient with chronic heart failure. So we have a 50-year-old male who is a diabetic and a hypertensive for the last 10 years. He's a smoker. He has come to the OPD with dyspnea on exertion NYHA class 2 for the last 3 months. So how on examination we see that his vitals, his pressures are raised. He has a blood pressure of 160 by 100. He has a normal respiratory rate. His pulse rate is also within normal limit. Saturation is 99%. There's no evidence of congestion in the body. There are no creps. There is no pedal edema. The JVP is not raised. His heart sounds are normal. There are no added sounds. We send the patient for an 12-lead ECG. The ECG shown here shows normal sinus rhythm with wide QRS, left bundle branch block, and a QRS duration of around 130 to 140 milliseconds. Subsequently, we scan the patient's chest. We do a chest radiograph. As seen here, it shows cardiomegaly. However, there are no signs of pulmonary congestion on this chest radiograph, which is consistent with our clinical examination of no creps and no raised JVP. This is the transthoracic echo of our patient, four-chamber view, typical four-chamber view, which shows that there is global hypokinesia. Subsequently, this is the short axis view, again showing global hypokinesia with an EF of 30 to 35%. We do routine blood investigations as in all our OPD patients. The hemoglobin is 11.8. The leukocyte and platelet counts are within normal limit. The RFT is normal. The LFT is normal. Essentially, all parameters suggest that our patient is stable. So what additional investigations? As discussed earlier, in all patients who are with heart failure with reduced ejection fraction, we need additional tests. Tests prognosticate our patient, tests to know the management of other comorbidities, to look for other risk factors. So what do we get? We investigate our patient for NT-proBNP. In an OPD patient, a value less than 125 helps us rule out heart failure, whereas a value of more than 125 picogram per ml rules in heart failure. We do further, because our patient is a diabetic, all heart failure patients need lipid profiles, HbA1c, blood sugars, thyroid function test. More importantly, iron studies, because around 50% of chronic heart failure patients have iron deficiency with or without anemia, which, if corrected, improves quality of lives, decreases hospitalizations. Lastly, to rule out an ischemic etiology for the LV dysfunction, we would like to do a coronary angiogram, which in our patient was normal. These are the mandatory investigations that I have discussed: a 12-lead electrocardiogram, a chest X-ray, a transthoracic echo, biomarkers in the form of NT-proBNP. Besides that, hemogram, RFTs, LFT, TFT, HbA1c, and iron studies. These are all mandatory investigations that should be done in all patients with chronic heart failure on their first visit once a diagnosis of heart failure has been made. So what is the final diagnosis of our patient? Our OPD diagnosis is he's a diabetic, hypertensive, heart failure with reduced ejection fraction, an EF of 30%, the etiology of HFrEF being DCMP. Our patient is a normal sinus rhythm with left bundle branch block. Currently, he was in NYHA class 2 and he has iron deficiency. So this brings us to the first question. What is the initial treatment for our patient? Is it A, telmisartan plus metoprolol? Is it B, ramipril plus metoprolol succinate plus digoxin? C, ramipril plus metoprolol plus spironolactone? Or will it be D, including Vimada, metoprolol succinate, spironolactone, dapagliflozin plus a low dose of a diuretic? Can we please do the polling, please? Can all of you just answer the question? I will wait for 20 seconds. So I've got the poll. 35% have answered it correctly, that the four pillars, that is Vimada plus metoprolol succinate plus spironolactone plus dapagliflozin. And I can now end the poll. Most of you, 48%, have finally answered the right answer. That is option D, Vimada plus metoprolol plus spironolactone and dapagliflozin. So I'm glad that most of us are on the same page. So let's move ahead. Beyond this, so this is the ESE algorithm, as has already been shown previously. The four pillars need to be prescribed in all stable patients with HFrEF, which includes an ARNI or an ACE inhibitor, a beta blocker, an MRA, SGLT2 inhibitor, and a low dose diuretic for fluid retention. So, what are the pearls of wisdom? Start with all four drugs. Start at low doses. Start at doses which prevent or forbid decompensation. So our aim is to start with all four pillars at very low doses, up titrate very slowly, up titrate them every 2 weekly. Over a span of the next 6 weeks, we want to reach the maximum tolerated therapies. As far as RAS inhibitors are considered, wherever the BP is on a higher side, prefer to start ARNI in the absence of any contraindication. If a patient has a borderline blood pressure, preferably ACE inhibitor would be safer in such a patient, as in the Indian population, most patients decompensate or develop hypotension with ARNI. So based on the initial blood pressure, we can choose whether an ARNI or an ACE inhibitor. ARBs are preferred lesser, should be avoided, and should be given to patients who cannot tolerate an ACE inhibitor. The most fundamental principles with RAS agents are that both ACE inhibitor and ARNI should not be given to the same patient at the same time. And when switching a patient from ACE inhibitor to an ARNI, a drug-free period of 36 hours is mandatory. It is crucial to avoid angioedema. Therefore, never switch over a patient from ACE to ARNI without a 36-hour drug-free period. This drug-free period is not required when switching from an ARB to an ARNI. Most importantly, give no patient a combination of ACE, ARB, and ARNI. It is forbidden. So let's move beyond the drug therapy. We have initiated this patient of ours on GDMT with 4 pillars. Besides that, we need to vaccinate all our patients annually, both with pneumococcal and influenza vaccines. If there is iron deficiency, we need to replete with IV ferrous carboxymaltose. Physical exercise and rehabilitation is key to increase his exercise capacity. Treat comorbidities like in our patient diabetes, heart failure, and iron deficiency. Patient education regarding drug side effects, regarding when he is worsening, when to seek care are crucial. We should advise our patient to avoid drugs that might precipitate heart failure, and a very close outpatient follow-up are crucial beyond the 4 pillars for management of chronic heart failure. So at follow-up, what does a clinician or what does a heart team member see? We look at six key principles. First, is our patient better? Are there any improvement of symptoms, or is there a worsening of symptoms? Is our patient fluid overloaded, or has he decompensated? So are there creps? Are there pedal edema? Is he having a raised JVP? We look at vitals. We can up titrate our medications to a systolic of 95 mmHg and to a heart rate of 55. Beyond 95, we have to be very careful while up titrating ACE inhibitors, ARBs, SGLT2, and MRAs. And below a heart rate of 55, we have to be doubly sure and very critical while up titrating beta blocker. Weight monitoring, as already discussed, more than 2 kgs weight gain in the next 2 to 3 days when a patient monitors his weight is a red flag and should warn the patient that he's probably decompensating and he should seek medical care. The most important principle of drug therapy for chronic heart failure is drug compliance and tolerance. And lastly, in all these patients, we have to be careful for renal dysfunction and dyselectrolemia. So we should be very careful with electrolytes and watch out for any renal worsening or any hyper or hypokalemia. So this patient of ours who we initiated on 4 drug medical therapy, now he comes for follow-up after 2 weeks. What are his symptoms? He's still class 2. However, there are no signs of decompensation. He's not in fluid overload. His pressures are still raised. He has a BP of 150/90, a pulse rate of 80. His RFT and electrolyte show no worsening. So at this point of time, what do? We have to up titrate our GDMT. As we can see, our patient is not decompensated. He's not fluid overloaded. His pressures are still very high. We need to decrease his pressures, which will decrease the afterload and improve his dyspnea. So what do? we rapidly up titrate his medical therapy. We can keep increasing the doses every 2 weekly. The rule is to do aggressive titration to reach maximum dose or the maximum tolerated dose within the next 6 weeks. We should then attain the maximum tolerated dose and continue our patient on the maximum dose for the next 3 to 6 months. Following those 3 months, we should reassess ejection fraction, symptom status. And if our patients, despite 3 months of maximum medical therapy, are still symptomatic, we need to assess for second line therapies. That is ivabradine, digoxin, and any alternate role of device therapy. Is there a role of ICD and CRTD based on the QRS width and the presence of left bundle branch block? This has been covered initially. These are the starting doses of all our pillars of therapy and the maximum target dose that one can achieve. Similarly, these are the starting doses of SGLT2 and ARBs as we have discussed. So our patient is now coming to us after 3 months. He's on maximum tolerated doses of all four pillars. He's on ARNI, beta blocker, SGLT2, and MRA at maximum tolerated doses. He has taken them for 3 months. Now, what are his symptoms? He still is NYHA class 2. However, on signs, there are no signs of decompensation or fluid overload. His pressures are still raised. He continues to have a BP of 150/90 despite having reached the maximum doses. And there is no worsening of RFTs or electrolytes. His echo is showing EF of still less than 35%. This is the time when we need to intervene. He has reached maximum doses of all four pillars. So we need to add the second line drug. So which is the second line drug which has shown to reduce hospitalization in patients with heart failure? Ivabradine. It has a class 2A indication, and in patients with normal sinus rhythm, heart rate more than 70, despite maximum doses of beta blocker and all four pillars, ivabradine is the next step. Besides ivabradine, we should also assess our patients for any augmented role of device therapy. So as you can see, once a patient is on maximum therapy, we need to add drugs with class 2 recommendations like ivabradine if still symptomatic. And in patients who have an EF of less than 35%, despite 3 months of maximum tolerated drug therapy, there is a role of ICD and CRTD based on the QRS duration and his NYHA class. So now let's see, our patient has maximum 4 drug therapy. He's on ivabradine. He's doing well. He comes to us at 3 months follow-up. Now patient notices that he has worsening dyspnea at rest. So our patient has worsened. On examination, he has pedal edema. His neck veins are distended. He says, I cannot lie. Every night when I'm lying, I'm getting very dyspneic. His examination, his pressures are raised 150/100. He's tachycardic. His pulse rate is 120. He has respiratory distress. His respiratory rate is 22. And he has desaturation at room air of 90%. We look further. His creatinine has doubled from his previously normal value. This is the typical phenotype that our patient of chronic heart failure has decompensated. He is an acute heart failure and as discussed previously, he is congested. He has bilateral pedal edema. His neck veins are distended. So he has wet phenotype. However, his pressures are high. He doesn't have cold peripheries. The temperature of his periphery is normal. So this is the warm and wet phenotype. So how do we approach? There are 5 important things. First, admit in ICU, monitoring of vitals, blood gases, electrolytes, and urine output. Second, increase the dose of diuretics. Increase it to 2 to 2.5 times the OPD baseline dose that he was taking. Initiate decongestive measures in the form of IV nitroglycerin to decrease the pulmonary capillary wedge pressure. Oxygenate our patient and possibly consider non-invasive ventilation for management of pulmonary edema. While his RFT has worsened to twice that of baseline, we would like to discontinue the MRAs, anti-RAS agents, and because he is in heart failure and might worsen, beta blockers can initially be held. Although it is to be mentioned that beta blockers can be continued at this point. However, just to be safe, we discontinue it. Beta blockers should be discontinued if the patient is in cardiogenic shock and may be continued if the patient is having warm wet phenotype. However, in most hospital settings, we tend to withhold our beta blockers during acute heart failure. Most importantly, investigate for the etiology of decompensation, rule out infection, rule out triggers, and target a urine output of 100 to 150 ml per hour with diuretics. The triggers that need to be ruled out are non-compliance to drugs, ingestion of drugs known to worsen heart failure, infections, arrhythmias, and most importantly, ischemia. This is the chest X-ray of the patient who was admitted to our ICU. You can see there is pleural effusion, there's congestion, there's cephalization of veins, and there are curly B lines. So we admit our patient, we decongest him, we slowly get him to a dry state, we initiate all four pillars slowly, and we discharge him. Our patient goes home. He comes for follow-up at regular intervals. He's fine. He's doing well. Now our patient comes to us 1 year later. And 1 year later, our patient says, I'm absolutely asymptomatic. I have no symptoms. On examination, no signs of congestions. His blood pressure is normal, 100/60. He has a pulse rate of only 70, respiratory rate, saturation, everything normal. RFTs, electrolytes normal. So our patient is again back to an absolute asymptomatic stage. He is in chronic heart failure, symptom free, on stable GDMT, NYHA class 1. So our patient says, Doc, do I really need to take these medications? I really want to quit. Can I please discontinue the drug treatment? Can we have the second question on board, please? So at this time, please vote for the second question. What do we tell our patient? Our patient who wants to discontinue. So DCMP patient on four pillars, his EF has improved from less than 35 to 40%. What is the long-term medical treatment? Do we discontinue all four pillars, any two pillars, only SG2, or continue all four pillars lifelong? So I'm very glad the polling shows that most of you, the vast majority, 75% have gone with the right answer. That is continue all four pillars lifelong. And where does this evidence come from? I will end the poll and we can go to the results show that 75% of you have chosen the right answer. That is continue all four pillars lifelong. And now let's go to the PPT. So TREAD heart failure. So withdrawal of pharmacological therapy for heart failure in a recovered DCMP patient who is NYHA class 1. The evidence comes from TREAD heart failure, which says that we need to continue medicines, as 45% of these patients, if we discontinue the medical therapy, will relapse and their ejection fraction, which has improved, will again go back to its baseline. So my take home messages for all of you are: patients should be initiated on all four pillars of therapy in HFrEF unless contraindicated, rapidly uptitrate to maximum doses within 6 to 8 weeks, reassess ejection fraction after 3 months on maximum GDMT. In patients who are symptomatic despite maximum GDMT, second line drugs like ivabradine should be initiated. Device therapy should be considered in patients who are persistently symptomatic and have an EF of less than 35% after 3 months of maximum GDMT. Continue GDMT lifelong, even in those with recovered EF and who are asymptomatic, and most importantly, treat comorbidities. I think the essence of heart failure care relies on team effort. So let's all join our hands, all cardiologists, physicians, and nursing care, to make our patients' lives better. Thank you so much for your kind attention.
Thanks, Devesh. That was an excellent case. So from chronic heart failure, we move on to a case of acute heart failure. Dr. Neha will present the case. Neha, please.
Good evening, everyone. First of all, I would like to thank HFAI and Dr. Sandeep Seth for this opportunity to train the backbone of our healthcare system, the nurses. So I'll start with this interactive case scenario on a patient with acute heart failure. So the patient is a 42-year-old male, a known case of dilated cardiomyopathy with an LV ejection fraction of 30%, baseline NYHA class 1, who presented to us with fever and cough with expectoration for 5 days. along with worsening of shortness of breath, such that he's even unable to lie flat. That is, he has orthopnea. On examination, his vitals are a BP of 100 by 58 millimeter mercury, a heart rate of 110 per minute, a saturation of 90% with bilateral basal crepitations and bilateral pedal edema. The extremities are warm to touch. So, what is the likely diagnosis and how should we approach a case like this? So, the patient has acute heart failure, which is characterized by a rapid onset of symptoms or signs of heart failure that leads to an unplanned hospital admission or visit. So, the diagnostic workup, as advised by the ESC guidelines and as Dr. Prerna has already discussed, includes taking a good history, examining the patient, and getting an ECG, checking the saturation, doing an echocardiography, getting the initial blood labs, doing a chest X ray, and a lung ultrasound if available, and a natriuretic peptide testing. So, let's say our patient had a hemoglobin of 14, counts of 16,000, suggesting an infection. Urea and creatinine of 55 and 1.5 deranged, suggesting acute kidney injury. Sodium and potassium within normal limits, and an NT-proBNP which was significantly elevated at 15,000. This is the ECG of the patient showing sinus tachycardia and features suggestive of dilated cardiomyopathy. This is just to show a comparison of the various X-rays. The X-ray on the left is completely normal. The X-ray in the middle suggests cardiogenic pulmonary edema. You can see the bat wing appearance classically, which shows perihilar opacities. There may be a few curly B lines which may or may not be visible in this image, but as Dr. Devesh had shown in his presentation beautifully, this is to compare with an X-ray showing just a consolidation in a patient with, say, bacterial lobar pneumonia, where you can see that there is a localized opacity compared to this image, which shows perihilar opacification. So, coming to my first question, based on whatever data I have shown you, which phenotype does our patient likely belong to? So, I would like to have the poll now. So, could all of you please answer the question and submit your response? I cannot see the responses yet. Okay, so we have a mixed response here. So around a third of patients answered that this was warm and wet. A few answered that this was a warm and dry patient. So let me just show you the correct answer. So the correct answer was warm and wet. So let me just go back to my case scenario so that things are clear for everyone. So the patient has a BP of 100 by 58 millimeter mercury. You can see that he has bilateral basal crepitations and pedal edema. So he is wet and the extremities were warm to touch. So this patient likely has warm and wet acute heart failure. So just to quickly revise what Dr. Prerna had also discussed beautifully. So we have 4 phenotypes of acute heart failure. So warm and dry is likely what we are targeting, where the patient has a good blood pressure, no hyperperfusion, and there is no congestion also. So warm and wet is what our patient actually belongs to, because the patient has pulmonary edema, creps, and pedal swelling. So congestion is there, but the pressure is still maintained. So there is no hypoperfusion. Had the patient had cold extremities without any pulmonary edema or pedal edema, this would have constituted cold and dry phenotype, which may have responded to fluids. And a patient who has low blood pressure with warm and wet, wet phenotype, it would have become cold and wet with cardiogenic shock. So how do we treat a patient with warm and wet phenotype? We would have given diuretics or vasodilators. Had the patient been in cold and dry phenotype, we would have treated with fluids. And had the patient had cold and wet phenotype, we would have treated with inotropes or diuretics. And if the patient does not respond to this, we would have considered mechanical circulatory support. So this is just to quickly review the doses of diuretics and vasodilators that we will use in this patient. So we initially start with IV loop diuretics. So the most commonly available one is furosemide in our setting. So we should give a dose of around 20 to 160 milligram IV or at least a dose which is between 1 to 2 or even up to 2.5 times the oral dose that the patient was receiving in OPD. And we should divide this into 2 to 3 doses per day. So let's say this patient was on torsemide oral, Ditor, 10 mg once a day. So we should know that the dose of torsemide is half of the equivalent dose of furosemide. And since the patient is in acute heart failure, we would give up to 2 to 2.5 times this oral dose. So in a patient who was on 10 mg torsemide, I would like to give at least 20 mg of furosemide twice a day IV. And we could also use an infusion. In these patients, we would want to monitor urine output, electrolytes, and renal function. If the patient does not respond to these drugs, there are other therapies like metolazone and spironolactone that we could add. For among vasodilators, the most commonly used one is nitroglycerin, which we start, as Dr. Prerna had already discussed, at a dose of say 20 microgram per minute, and can increase it up to 400 micrograms per minute while watching for hypotension. And it is important to remember that tolerance can develop after 24 hours. So we may have to taper and stop the therapy transiently and restart again. And these are the doses of the inotropes that Dr. Prerna had already discussed, so I will not spend too much time on this slide. So another important thing that we need to do in patients with suspected acute heart failure is to look for the etiology. So I want you to remember this simple mnemonic, CHAMPIT. So C stands for acute coronary syndrome. We should look for STT changes. We can look for a troponin elevation. A hypertensive emergency is what it stands for. A stands for an arrhythmia. It could be a tachyarrhythmia or a bradyarrhythmia. M could be a mechanical cause. P would be pulmonary embolism. I would be infections, like in our case, and T would be for tamponade. The example of a mechanical cause could be, for instance, aortic dissection. So our patient who was warm and wet, we propped him up and started him on oxygen support via nasal prongs, intravenous nitroglycerin infusion at 20 microgram per minute. We gave him IV furosemide boluses 20 mg twice daily, and we started IV broad spectrum antibiotics for suspected respiratory tract infection. So coming to question number 2, after 3 hours of starting therapy, our patient develops hypotension with now a blood pressure of 76 by 40 millimeter mercury, pulse rate of 120 per minute, and saturation of 88% on oxygen at 3 liters per minute, with no improvement in Krebs or pedal swelling. So what is the first change in therapy that should be made? So could I have the poll, please? So I request you all to answer. I want you to think of the first thing that you would do in our patient. So we again have a mixed response in this. So let me just show you the correct answer. So the correct answer is, the first step would be to stop nitroglycerin. Because we had started nitroglycerin, the patient's blood pressure has dropped. The first thing that I want you to think of is stopping the nitroglycerin, and then we will start the vasopressors eventually. Another important thing to remember is that the patient's congestion has not improved. He still has Krebs. So we would not stop IV furosemide. We cannot give IV fluids because the patient is congested. IV dobutamine should not be started in a patient with hypotension. We should first try to bring up the blood pressure, and then we can start IV dobutamine as tolerated. So in this patient, IV nitroglycerin was stopped, and we started with vasopressors. We started norepinephrine infusion at 0.2 microgram per kg per minute and slowly uptitrated it. And IV furosemide was continued. Oxygen support was increased. In this patient, since there was hypotension, we did not start non-invasive positive pressure ventilation. We can consider that if there is no improvement on oxygen and if the pressure improves. So let's say the patient's vitals started improving after 3 hours. The BP was 96 by 60, heart rate was 105 per minute, saturation was 95% on oxygen at 6 liters per minute. So we started him on IV dobutamine infusion at this point at 2 microgram per kg per minute, along with the norepinephrine. Let's say he improved over the next day and was weaned off inotropes, and he was shifted to the ward in the evening itself. So in the ward, the patient was unable to sleep at night due to persistent orthopnea and had recurrent coughing. On examination, the blood pressure was 97 by 70 millimeter mercury, heart rate was 116 per minute, and the saturation was 93% at room air. An enthusiastic junior resident attributed the symptoms to tachycardia and started the patient on metoprolol succinate, 25 mg once daily. The patient developed worsening hypotension with the blood pressure plummeting to 75 by 50 millimeter mercury and heart rate of 80 per minute. He was shifted to the ICU again for stabilization. So what must have gone wrong? I would like you to think about this for a few seconds. And if you could respond on the chat box. So likely what went wrong was, first off, that maybe the patient was shifted a bit too soon to the ward without adequate decongestion. Secondly, the patient should not have been started on metoprolol succinate, which is a long-acting beta blocker, as discussed before. So the symptoms were not likely because of the tachycardia. It was probably because the patient still has not been adequately decongested. So the tachycardia is a response of the body to that. So beta blockers, especially long-acting, should only be initiated after complete decongestion. I want you to understand this so that you are also able to recognize if a doctor goes wrong at any point. So let's say the patient was stabilized again with IV inotropes and diuretics. He was weaned slowly off inotropes this time and oxygen support over the next 2 to 3 days. His vitals were stable. BP was 100 by 68 millimeter mercury. Heart rate was 96 per minute. Saturation was 98% at room air. There were no creps. JVP was normal, and the patient had documented weight loss of around 5 kg. So now how do we plan transition to oral therapy? So after stabilization, he was started on, we will gradually reintroduce the 4 pillars. So he was started on tablet torsemide 20 mg once a day, spironolactone 25 mg once a day, and dapagliflozin 10 mg once a day. Okay, so the tablet sacubitril valsartan 24-26 half tablet BD was started the next day. His creatinine now increased from 0.8 to 1.2 over the next 3 days. So what should be the next step? So excellent. I'm glad everybody is on this same page as us in this regard. So most of you have answered correctly. So we should continue therapy and monitor the KFT or electrolytes in this case. So the idea is that lowest possible dose of loop diuretics should be given orally to maintain decongestion. Once AKI has recovered, low-dose ACE inhibitor, ARB or ARNI, in our case, we could have started ACE inhibitor because the pressures were on the lower side, or if tolerated, ARNI can also be given. And a mineralocorticoid receptor antagonist, for instance, spironolactone, should be initiated. And a mild increase of up to 50% of baseline in creatinine is expected at the time of decongestion and starting of these therapies. So it should not raise any alarm. If the rise is more than 50%, we can halve the dose of these therapies and repeat the KFT. If the potassium rises to, let's say, more than 6 millimeter equivalents per liter, we must stop these drugs, correct hyperkalemia, and reinitiate at lower doses after normalization. Also, SGLT2 inhibitors should also be started before hospital discharge. We should beta blockers should be initiated with caution in patients with recent worsening of heart failure only after complete decongestion. For instance, we can start with metoprolol succinate 12.5 once a day. So we try to start all 4 pillars of therapy at very low doses and try to up-titrate them gradually. The idea is that we should try and start all 4 pillars before discharge. Another novel therapy that should be considered in patients with worsening heart failure, despite the 4 pillars, is vericiguat, which can be started at 2.5 once a day and can be increased up to 10 mg once a day. Apart from this, we should be advising salt restriction and daily weight monitoring following discharge. And the patient should be followed up at 1 to 2 weeks post-discharge for therapy titration as tolerated. Thank you.
So with that, we have completed the 4 main sessions that we were planning to have, and I'll now start winding off this session. Just give me a second. So we have covered most aspects of heart failure. We went from chronic heart failure to acute heart failure. We discussed a case of chronic heart failure and then acute heart failure. And by now you would have realized that the management of heart failure is relatively complicated and yet simple at the same time. Complicated because there are multiple facets which have to be treated, not just the drug therapy, but prognosticating the patient, ensuring the patient takes medication. So there are lots of aspects. So let's just quickly go through all that we've discussed today. We know that heart failure, we had this in the last sessions. Heart failure is basically a pump failure. The heart is not pumping blood to all the parts of the body because the function is down. That means heart failure will reduce ejection fraction, or it's pumping it at higher filling pressures. That means the heart is stiff. The ejection fraction, as we see it, is normal, but the heart is stiff, so heart failure preserved ejection fraction. This leads to fluid congestion in the lungs, causing shortness of breath, and the legs, causing edema. We have discussed that there's heart failure with reduced ejection fraction, mildly reduced ejection fraction. Basically, ejection fraction less than 50% is treated similarly, and heart failure with preserved ejection fraction, where the ejection fraction looks normal, patient is in heart failure, but there is something as abnormal. For instance, there's hypertension, hypertrophic cardiomyopathy, various other conditions like this. We also discussed the kind of symptoms that we have, so shortness of breath, swelling of the feet, and lots of other symptoms. I won't go into this again. Investigations were discussed. What is very important that you have to talk to the patient, listen to the patient. Ask the patient, how is the patient, as Prerna started, how are you feeling today? If the patient says he's very good, you are rest assured that you don't have to worry too much. You can focus on seeing what do you want to up titrate or down titrate. If the patient seems feeling bad, then definitely spend a bit of extra time trying to figure out what is wrong with this patient. We discussed the investigations. So besides the history, going on to the simple thing like ECG, X-ray, biomarkers, echocardiography, then trying to find the cause for this heart failure. Is it coronary artery disease? It is a cardiomyopathy or a valvular heart disease. So these investigations will give an answer to that. Sometimes you need to go into the family history, do a genetic test, maybe even an MRI. So all these tests are very important to find a cause. Treatment has really evolved. So if you see this picture, this is a time when people did not understand heart failure. They just saw that patients were swollen. So they tried to remove that swelling. There was not even a concept of what exactly is the circulation. So bleeding the patient, putting blood-sucking leeches, we definitely advanced much beyond that. Starting with the initial forms of therapy that we had, strict bed rest, fluid restriction, giving drugs like digoxin, digitalis, and some of the older diuretics, which were relatively toxic, to the current form of therapy, which includes neurohormonal interventions like ACE inhibitors, ARNI, beta blockers, SGLT2 inhibitors, and mineralocorticoid receptor antagonists. Beyond drug therapy, then we had advances where devices started coming in. So defibrillators, cardiac resynchronization therapy for left bundle branch block, and finally, if all else fails, the possibility of a LV assist device or a heart transplant. There was a phase when we have tried to look at stem cell therapy or gene therapy, basically because if it's a failing heart, we want to try and regenerate the heart. And now again, we have a phase where newer and newer drugs are coming in. ARNI has come in. Ivabradine was a relatively newer drug. Newer drugs, the SGLT2 inhibitors, which were initially tested for diabetes, but now have been found to be useful for heart failure. Also, very Sigvard. Finerenone is another drug. We're looking at non-surgical ways to tackle some of the causes of heart failure. For instance, if there's mitral regurgitation, we can put a mitral clip. If there's severe aortic stenosis, not suitable for surgery, we can actually percutaneously replace the aortic valve. So treatment for heart failure is advanced, and if you'll be right in saying that most patients of heart failure can be given some form of therapy. Focusing on the role of nurses. If you have so many facets of treatment, obviously a single doctor sitting in the OPD cannot manage these patients. You have to have force multipliers, and the heart failure nurses are the force multipliers because outcomes will improve with nursing intervention. As nurses, you have to focus on ensuring adherence to medication for these patients. Even in the best of circumstances, we have found that only about 25 to 50% of most of the patients actually take all the drugs that we have prescribed. Something goes wrong. And when you're talking to these patients, you should be able to figure out what was wrong. Why did the patient not take the medicines? Was it too expensive? Did he not understand the medication, or did he have side effects? So counseling is very important. You teach the patient that, look, you have heart failure, but you can go through with life normally. You have to take the medicines on time, but continue your life. Lifestyle changes have to be taught to the patient by repeatedly emphasizing that when you have heart failure, take a bit of less salt, take less fluid. And it's very important to follow up with the doctor on a regular basis. Just because you're feeling better doesn't mean that you don't come to the doctor again. So de-emphasizing, teaching the patient medication management, educating the patient about various aspects of heart failure, teaching the patient how to monitor the symptoms and vital signs. They should know that they have to keep an eye on the blood pressure, heart rate, look at their pedal edema, and also monitor the weight, because sudden gains in weight would suggest fluid accumulation rather than developing obesity. The nurses have a key role in coordinating between physicians, pharmacists, physiotherapists, dietitians. So they are in the center of the heart failure management. You will sit with the patients to simplify medication schedules. Sometimes patients take medicines 4-5 times a day. We teach them that, look, we can take medicines only 2 times a day or thrice a day. As Prerna showed, you can use pill organizers, calendars to improve the medication adherence. And always encourage the family to be involved in the management of these patients, because sometimes the patients will forget the medicines. The family should be able to remember that. Always double check the prescription. Don't just think that just because the patient has shown you the card on which the medications are there, he's taking all the medicines. Always ask the patient, okay, tell us what medications are being taken by you. If necessary, show the tablets and capsules which are there. You are taking that confirms that medication adherence. Sometimes it can happen that duplications take place. Patients taking medications from 2 different cards or 2 different hospitals. For instance, he's taking medications from a cardiologist and a nephrologist. So doses can be doubled or deleted. So you have to be very careful in being able to pick up these mistakes and teach the patient. You have to learn to talk to the patient and to be able to teach him very well about the correct timing and what to do if you missed a dose. Suppose you missed a dose of diuretic, we take the diuretic later. Same for ACE inhibitor, other drugs. Patients should know why each drug is being taken. Patients sometimes comes to us and say, I've stopped all the drugs you gave me because my blood pressure is well controlled, so I'm not hypertensive anymore. Or why are you giving me drugs for diabetes? I don't have diabetes. SGLT2 inhibitors are basically used for diabetes, but they're now being repurposed for heart failure. So you have to explain the purpose of each drug to the patient, explain the common side effects. Commonly, the patient's blood pressure can fall when you start vasodilators. So you should tell them that this can happen. If there's only a slight fall in a blood pressure, don't worry. But if you have symptoms, you should know which drugs can cause this. So all your vasodilators can cause this problem to some extent. Your nitrates, your beta blockers will also cause this problem, less likely with SGLT2 inhibitors, and very sick, though they can also cause slight fall in blood pressure. So patients should know about these drugs and should know what to do if something like this happens. That means you teach the patient, okay, if you feel giddy, sit down or lie down and ask someone to raise your legs. BP will come up, take some water, and then have a relook at your medication, maybe talk to your heart failure nurse or your doctor. They should be taught self-monitoring. They should all keep an eye on the blood pressure, heart rate, and weight. And they should not stop their medications without advice from a doctor or a nurse. So as I emphasize, daily weight check, same time, same scale. Preferably when you get up in the morning, go to the washroom, come back, and then check your weight. Track the main symptoms. Is there any swelling over the feet? Are you feeling breathlessness, which was not there maybe a week ago? Suddenly start feeling more breathless, more fatigued. Keep a symptom diary. Any sudden change should be reported to the clinic. So we've covered the medication, general advice like salt and water restriction. We talked about various drugs for heart failure management, various devices like defibrillators, CRT devices, and finally, LVSS devices in heart failure. Just to re-emphasize something we've discussed already, encourage the patient to reduce water and salt, and tell them also to take lots of fresh fruits and vegetables because they will deplete the minerals which are being lost due to diuretics. Some of the things we teach the patients is that avoid processed food, avoid processed vegetables from outside. Read the food label, because some processed food have already high dose or high level of salt in it. Since we're asking the patients to reduce their intake of salt and water, patients might find the food insipid. They can use as much of spices as they want. We also want to add potassium magnesium sources. For instance, you can advise them to take some coconut water, lemon, citrus fruits, apples, tomatoes, and obviously cut down fat. So all these things are very useful. Remove the salt shaker from the table. Salt intake will come down. Cut down on processed food outside. So don't take double cheeseburgers and don't take bhaturas and puris all the time. These are some rich potassium sources. So citrus fruits or colored fruits, coconut water, very rich in potassium and other minerals. We already covered the drugs, so I won't go into them. We use one of the vasodilators as a start of therapy. We give diuretics like loop diuretics to improve the symptoms, and potassium sparing diuretics because they are good for long-term prognosis. SGLT2 inhibitors we just covered are very important. They were initially meant for diabetes, but now are being used increasingly for heart failure. Beta blockers, as was emphasized, we start on a low dose in patients who have stabilized and gradually go up on the doses with each visit. So I'll re-emphasize this. This was also emphasized by Neha in the case she had. Start with very low doses, go up on doses slowly. Do not give the patient beta blockers if the patient is in the ICU, bedridden, not walking, or has fluid overload. Do not use it in patients who have recently just come off IV inotropes and also have fluid retention. So you have to give beta blockers, but wait for the patient to start walking around. We talked about ivabradine. So the newer drugs we've covered, so drugs like very sick gut, which is basically used only for very sick patients, advanced heart failure, it has been found to be beneficial. Finerenone is a new drug which is coming up. It's basically a mineralocorticoid receptor antagonist, which has very few hormonal side effects. So it's been found to be useful, first of all, in heart failure, preserved ejection fraction. Heart failure might reduce ejection fraction. So it may have a role in the future. Should not forget second-line drugs like digoxin. Has been always found to be useful, though because it has narrow safety margin, it can cause side effects and very severe arrhythmia, so have to be used very carefully. We have discussed the guidelines. The guidelines are very simple. It started what we call the 4 pillars of therapy: ACE inhibitors or ARNI, beta blockers, MRAs, and SGLT2 inhibitors. Beyond that, you want the patient to be dry, so go up on diuretics initially. If the patient has indications for additional devices, so CRTs and ICTs can be put. And beyond that, of course, you have various other things to do. Coronary artery disease, bypass surgery, if there's iron deficiency, give IV iron, atrial fibrillation, you treat with digoxin. And for any valve regurgitation, you can consider surgery or a non-surgical repair. If all this fails, then of course, we have more advanced therapy like LV assist devices and heart transplant. And this is a question which was asked on the chat boxes. Lifestyle changes. So exercise rehabilitation is very important. And we have to remember this is teamwork, so everyone has to work together to improve the outcome of these patients. Now, what happens if drugs fail? This is an algorithm which we're trying to develop. If in the past 6 months, patient has had a hospitalization or organ dysfunction is persisting in terms of renal or liver dysfunction, the natriuretic peptides are not coming down. They're staying above 1,000 or 2,000. Patient cannot even walk for 5 minutes or climb one flight of stairs. If any 2 of these are there, patient is very likely to have a major event in the next 6 months. So you have to think in terms of advanced therapies like an LV assist device or a transplant. And all these options are freely available in India. So we should always think that patients can be treated. If drugs fail, then heart transplant assist devices are there. Looks too complicated, true. That is where the heart failure nurses come in. These are just some of our nurses. And the nurses are important because they will be the interface between the doctor and the patient. They can educate the patient, they improve the therapies, they maintain checklists. They can be like physiotherapists also because they can train the patient in various exercises. They maintain a telephonic helpline. There's just some glimpses from a heart failure clinic. The patients are getting counseling. They're being checked for vitals. They're going through an exercise session, yoga session, a telephonic helpline is being maintained. Prerna talked about the heart failure checklist in the ward. This is the checklist that we use in a heart failure clinic. Very simple one. We write the demography of the patient quickly. We ask a simple question: are you same, better, or worse than before? Can you climb one flight of stairs? That straight away lets us know how the patient is. And as Chitesh showed, the ABCD of heart failure management, that patient should be on all classes of drugs. And if the patient is not on a particular class of drugs, we should write down why the patient is not on that class of drugs. It's a very simple checklist. Takes hardly 3-4 minutes to fill. This I won't go into again, but Prerna had covered this in detail. If the patient is admitted in the ward with acute heart failure, how do you give the diuretics, when not to give the diuretics, when and when not to give inotropes, SGLT2 inhibitors, very sick, but always remember iron, when to start ACE inhibitors or ARNI. Beta blockers, of course, you have to be very careful that you don't give it too early, but don't forget to give beta blockers, and always treat the other causes, vaccination, and also a discharge appointment. The patient should know when to come, whom to come to within 7 days of the discharge of heart failure. We follow other small tools. For instance, we put a stamp on that patient's card in which ABCD is written, and we categorize the prescription in that format. Makes it easy for us and the patient to remember the drugs. We have something called the Hriday card. It basically has pictograms at the back to help educate the patient, contains the details of the hospital, the patient, and any helpline numbers on this. Inside, there are monitoring charts, so you can monitor the medications and the weight also with that Hriday card. So in brief, that is what heart failure management is all about. So if you do it properly, at the end of the tunnel, there is light, and you give hope to all these patients. And now with that, we'll just take up a few questions. We can start the poll simultaneously, Vinay. So our first question is, in a patient with left-sided failure, which symptoms are most characteristic? Is it peripheral edema, ascites, dyspnea on exertion, or jugular venous pressure? Jugular venous distension. So left-sided failure, which is the most common symptom?
There are 7 questions. Everyone can scroll the.
There'll be lots of questions, so you can scroll up and down, but I'll discuss these questions at the same time. So most of you have got it correctly. Left-sided failure means the congestion is on the left side. So the left side congestion goes to the lungs. So shortness of breath, dyspnea will be the commonest symptom. So the next question, which laboratory test best reflects fluid overload and cardiac strain in heart failure? Which lab test will reflect fluid overload? This is troponin I elevation, BNP, NT-proBNP, CKMB, or C-reactive protein. So please respond to the second question. Vinay, the second question on the poll. Vinay, can you have the second question on the poll?
Oh, yes, sir. I think a button was clicked.
I thought I was supposed to end poll for the second question.
No, I will do it, sir.
Okay, fine. I will
It's
stay
all in
away.
a single.
Yeah, okay. So can we have the second question now?
It is all in a single window only, sir.
Okay,
Everyone
fine.
can
I
scroll.
got it. So the second question was, which laboratory test best reflects fluid overload and cardiac strain? Very good. I think all of you got it correctly. It's BNP or NT-proBNP. Both of these are stretch markers. So when the heart is under stress, the BNP, NT-proBNP goes up. Troponin is for cardiac injury. CKMB is for cardiac injury. C-reactive protein is for inflammation. So the third question is, which nursing action is most appropriate for monitoring fluid status in a heart failure patient? I don't have to discuss this. I think all of you got it correct that monitoring daily weight is the most important thing. Perfect. Very good. I think you're getting all the questions correct. Which dietary advice is most important for a patient with chronic heart failure? Restrict fluid and sodium intake. So now the next question, which finding indicates right-sided failure? So right-sided failure basically means it's peripheral congestion. So yes, most of you got it correctly. It's peripheral edema and hepatomegaly. And see, most of the patients with right-sided failure will later on they can develop some amount of orthopnea, but right-sided failure would mean something wrong with the right ventricle or the pulmonary artery, so they're less likely to develop crackles in the lungs and orthopnea. So third out sound will not occur in cause of right-sided failure. So now next question is, which medication improves survival in chronic heart failure? Calcium channel blockers, beta blockers, loop diuretics, and nitrates. So okay, here it's divided, but let me explain this. Calcium channel blockers have not been found to be useful in patients with heart failure. Loop diuretics like furosemide and torsemide are very good for improving symptoms, but in long term, when they've been compared to other drugs, they have not improved the long-term survival. So there's no mortality benefit. Similarly, with nitrates, they will reduce the preload initially in heart failure. So they're very good for managing acute heart failure. But in the long run, nitrates alone have not been found to be useful for heart failure. So the correct answer is beta blockers. And finally, the nurse teaches a patient about warning signs of heart failure worsening, which symptom would require immediate medical attention. Most of you again have got it correctly. That weight gain, if you gain more than 2 kg in 2 days, then definitely you have picked up fluid in the body, and that fluid needs to be taken care of. And you have to teach the patient that if you're gaining weight suddenly, go up on your diuretics. We always teach the patient which is a water pill. So go up on your diuretics, and then if necessary, also look at your fluid intake. Have you started taking more of water? So that is basically the fluid management. I think that's the end of the poll. Vinay, we can stop the poll. We have finished on time. So now we'd be very happy to take some questions. If there are any question in the chat box. So Shatrughan has asked a question. What is the algorithm for heart failure for hypertension management and renal failure with severe hypertension? Shitish, do you want to take this question? Okay, so I'll answer this question. If you have hypertension and renal failure, so you cannot give drugs which are nephrotoxic. So the drugs which will be safe in this situation for heart failure and renal failure will be drugs like hydrolyzine nitrate combination. So you can give these drugs. You can give diuretics. You can give beta blockers. And if it's mild renal failure, you can also give drugs like SGLT2 inhibitors and Vericiguat. So that is what you can do. Okay, next question on spices. Basically, you can use chili, you can use herbs, you can use dhania, pudina, basically anything except salt. You can add it to make the food more tasty without actually adding salt. So pepper can be used. All forms of spices, chili, green chili, red chili, all these can be used. They will not cause any harm. Then in patients with chronic heart failure, how can nurses differentiate between symptoms of fluid overload and side effects of medication like diuretics or beta blockers during daily monitoring? So if a patient develops pedal edema, patient starts having shortness of breath, and there is a compression in the lungs, so that is fluid overload. Diuretics will cause side effects of mineral loss, so they can cause some restlessness in the legs. Beta blockers, if you titrate very fast, if you go up very fast, like in the patient which was discussed with by Neha, then it can cause symptoms of fluid overload. So if you give extra diuretics, it can cause fluid overload. Is there a need to develop a heart failure program for CKD patients, since most of the time they're missing out on signs of heart failure? Yes, I think most of your cardiologists would know how to manage a patient with heart failure with CKD. But a separate program can be there for as a heart failure clinic, but specifically creating a program for heart failure plus CKD may not work out. should we monitor iron profile of patients with heart failure, renal failure? For heart failure, yes, you look at the renal profile once because at least half the patients have iron deficiency, irrespective of the hemoglobin. And as I discussed in the chat box initially, patients with heart failure can have anemia because of various causes. For instance, because of nutritional causes, it can be iron deficiency anemia. Renal failure will have anemia, but will not have iron deficiency. So there, the treatment will be erythropoietin rather than iron. Besides that, chronic disease, inflammation in heart failure, bleeding because of antiplatelets, all these can be causes. So if you have anemia, you have to look for a cause. Is it iron deficiency or something else? But irrespective of anemia, patients, even with what looks like normal hemoglobin, can have iron deficiency, which responds to IV iron. In renal failure, hemoglobin will be lower. Yes, in renal failure, hemoglobin will be lower. Sometimes it is iron deficiency, sometimes because of renal failure. In that case, erythropoietin has to be given. 4 pillars, is it the same for pediatric patients? In pediatric patients, we use the 4 pillars, except that we don't have such strong evidence because so many trials have not taken place. We do use one of the vasodilators in stable children. We can cautiously use beta blockers, SGLT2 inhibitors. There is a small trial with ARNI. So ARNI is approved for heart failure. But you have to understand, in pediatric cases, the causes can be somewhat different also. They can be congenital heart disease. There might be more treatable causes. So to that extent, the management of pediatric heart failure will differ to some extent. In cardiac failure, can the ejection fraction be increased with medication? Yes, to some extent, especially with reversible causes. Suppose the patient has CKD and uncontrolled hypertension. Then if you treat the patient, even myocarditis, peripartum cardiomyopathy. So all these causes, if you treat the heart failure, treat the cause correctly, ejection fraction does improve. I think that's the set of questions we have. And I would like to thank Devesh, Kshitij, Neha, Prerna for the excellent presentations. Much better than what I would have talked probably. And Vinay, would you like to have someone with the closing comments or should I close?
Sorry, sir.
Can we finish now? It's 9 o'clock.
Yes, sir. Yes.
Okay, so thank you everyone for this presentation. I can see that there are more than 600 participants, and I'm sure you understood a bit more about heart failure, and we're looking forward to the next session in 2 weeks. So thanks, Devesh, Kshitij, Neha, and Prerna, and Vinay and Videhi. Thanks for this wonderful session. Thank you very much.
Thank you, sir.
Thank you,
Thank
sir.
you, everyone.
Thank you.
Thank you, sir.
Okay.
Okay, so we close now.